Suicide. Purposely taking one's own life, the ultimate form of self-destruction, involves intense feelings of fear, loss, anger, and despair. Effects can be devastating and long-lasting, and nurses must recognize a suicidal risk. According to medical practice, severe suicidal ideation, that is, serious contemplation or planning of suicide, is a medical emergency, and that the condition requires immediate emergency medical treatment. Suicide. The risk of suicide is greater in families where relatives have completed suicide. Successful suicides show a low 5-HIAA in body fluids, and adolescent attempts most likely would be in the home. Different people handle different situations in different ways, but there is a fact of life that no matter how old you become, we all need to be on the lookout for warning signs. Now, these statistics should alarm you. Suicide causes 13 deaths out of 100,000 every year, and the leading cause is the 15 to 24 age group. Males over age 65 have 4 times the national average of completed suicides. It is increasingly in the elderly population and more common in divorced and separated men. Suicide potential. Now, this is measured by the rationality of the client, the plan, the means of carrying out this plan, and alcohol definitely influences the suicide risk by decreasing the decision-making time. Suicide attempts. Many accidents are misclassified as non-suicidal, and that the accidents actually may be a suicide. It is more common when we're looking at these is that the successful suicides, the attempts, are more common in women. However, completed suicides are more common in men. Suicidal ideations, those thoughts that they have, many again are going to include firearms, medication overdoses. There are those that attempt and they fail are likely to try again. Suicide and psychiatric illnesses, and when we're looking at they're related, there's an increased risk. Unipolar and bipolar depression, the attempted suicide between 25 to 50%. In schizophrenia, we had read earlier that it was 10% of schizophrenic patients complete suicide, mainly because they feel socially isolated, and alcohol and substance abuse. Now, people who receive support from caring friends and family and have access to mental health services are less likely to act on their suicidal impulses than those who are isolated from sources of care and support. Medical conditions and suicide. Now, all the conditions you see listed on the left side of the slides involves the brain centers that affect judgment and mood. Epilepsy, cerebral vascular disease, dementia, visual defect, multiple sclerosis, head injury, brain tumor, and medications that have demonstrated to decrease suicide risk: antidepressants, atypical antipsychotics, and sedative hypnotics. Theories of suicide. Sociological. That there is a social disconnection, and in that social disconnection they feel that they have a loss of control. Psychological. Psychological pain can be just as debilitating as physical pain. Biological. Their neurotransmitters has an imbalance, or it could be genetics, and that the brain centers that affect judgment and mood will have these neurotransmitter imbalances. And then PEPLAU provides direction on how to intervene, that the 3 factors affecting suicide ideation, pain, perturbation, and press. And depression paradox results from conflict between feeling helpless to not able to change the situation that they're in to responsibility because they're supposed to care and provide for their family. The special populations. The 3 leading causes of death in adolescents and young adults are accidents, homicide, and suicide. And the elderly, they can decrease loneliness for many of them if they have pets. They live longer. They live for their pets. People that visit. The incarcerated, they have a higher suicide rate altogether than a general population, and it occurs more often. Suicide survivors. It is very traumatic for friends and family, even though people that attempt suicide often think that no one cares. Friends and families of successful suicide may have more stressful grieving process. They experience anger and sadness. They'll have feelings of grief and guilt, anger, resentment, especially over unresolved issues. There is a stigma surrounding suicide can make it extremely difficult to deal with the grief. And the lowest suicide rate, it will be peacetime military personnel. 4 methods of hastening death. In euthanasia, medication is injected into a patient, a lethal dose. In physician-assisted suicide, the physician prescribes a lethal dose of medication to the patient. And then when we're looking at withdrawal of life-sustaining treatment, that is stopping care for the patient. And then suicide would be at their own hand. Physician-assisted suicide is not generally an indictable offense as long as the physician is not administering the medicine. And double effect is that provide medically needed analgesia to terminally ill patients, even though it may shorten a patient's life. However, this is not physician-assisted suicide. It's the difference between physician-assisted suicide and double effect. You give medicines to relieve their pain and suffering, even though it may shorten their life. And for other patients that may request physician-assisted suicide, it could be a way for them to regain control. Suicidal warning signs: withdrawing from friends and family, depression. Broadly speaking, that they're not necessarily looking at a diagnosable mental illness like clinical depression, but these ones, they are just loss of interest in any activities that they normally would have found pleasure into. There's signs of sadness, hopelessness, much more irritable, lose temper quickly, changes in appetite, weight, behavior, level of activity, or sleep patterns. And there is no typical suicide victim. It happens to the young and the old, and to the rich and to the poor. More suicidal warning signs: loss of energy, making negative comments about themselves, recurring suicidal thoughts or fantasies. Sudden change from extreme depression to cheerful new energy might indicate that they have decided to attempt suicide. Talking, writing, or hinting about suicide in previous attempts. And a person attempting suicide is often so distressed that they are unable to see that they have other options. Possible approaches. Whether we have the direct approach. Are you feeling so bad that you're considering suicide? That sounds like an awful lot for one person to take. Has it made you think about trying to kill yourself? About killing yourself to escape? Has all that pain you're going through made you ever think about hurting yourself? Have you ever felt like throwing it all away? And then when you look at even maybe some other ones that you might do is an indirect approach. Do you ever wish to go to sleep and never wake up? That would be considered an indirect. You seem very unhappy. Are you thinking about ending your life? That might be another way of an indirect approach. So how do you help? They need love and understanding and care, and listen some more, and take them serious. Don't try to rescue them or take their responsibility. And if you're not sure, it is always best to call the Suicide Crisis Hotline. The effect on family and friends, it is so traumatic. For many of them, there is the stigma that attaches to it, that they feel that the loved one would rather have ended their life than to stay there with the family, and many feel that it is called a disenfranchised grief. Assessment, looking at the presenting symptoms. Do they have a history of manic or depressive cycles? Are they sticking with their medications? Are they taking it? Many of these clients might require more assessment, and suicidal ideation are those thoughts about wanting to die. Suicide is often interpreted as a cry for help and attention, or to express desire and the wish to escape rather than a genuine intent to die. Patients with psychiatric diagnosis are at an increase for suicide under assessment. The deadly triangle, dual diagnosis especially, when we talk about depression and alcohol abuse. And in adolescence, it is increasing in an alarming frequency and severity of the suicide attempts. Conduct disorder, depression, and substance abuse all lead to increased suicide in adolescence. The nursing diagnosis, these needs are grouped into categories. You have safety and physical needs, social, cognitive, and family, with the safety needs being primary. Outcome identification. Safety and physical needs are met first. Social needs are next, and then assisting the client to manage their illness. We're looking at success from PEPLAU is that it would verbalize hope for the future, or a patient may say, I have no thoughts of suicide or plans to harm myself. In NCLEX land, you might see a question where it would be if someone is attempting suicide, would you call for a chaplain? But make sure that you always address safety needs first before you do anything psychosocial, like calling a chaplain. Planning and interventions, safe and structured environment, concise and clear communication is so necessary, and they really need to kind of be off on their own initially. Your minimal social contacts until stabilized, because it's other people that had caused them to probably commit suicide in the first place. Prevent any embarrassing situations that might throw them over the edge. Focus on teaching the client to manage their disease and assist the family as needed. Getting them alone really can help focus on managing their feelings without feeling like they have to put on a show for other people. And then evaluation. Check check potential hazards, compare functioning to beginning of treatment, and view the progress in terms of degree, and this recovery process could take a very long time.